So recently we got scheduled for a posting at IWK Hospital. Now IWK is a tertiary care center in Nova Scotia, Canada, and today I'm going to show you how was a week in life of a pediatric dentist. IWK Health Center provides a tertiary care, which is a highly specialized and complex care for children and other group of patients. There is also some primary care as well as secondary care, but this is one of the kind of hospital in the Atlantic provinces. So IWK Dentistry team serves children and youth under 16 years of age who have special dental needs that cannot be met at a community dental clinic or a regular dental clinic. And the dentistry clinic is on the first floor of the Link building. In this video, I'm going to show you two very amazing things. Number one, how is life of a pediatric dentist in Canada? I am a dentistry student, third year at Dalhousie University doing my Doctor of Dental Surgery program, and we got our rotation at IWK Children's Hospital. So I'm going to show you insights and a lot about how was a week in life of a pediatric dentist. Number two, I'm going to also teach you some amazing concepts on pediatric dentistry that we as a student get tested on, that I know comes in national board exams and various other competitive dentistry exams. Look at my schedule. I have classes arranged throughout the week. There are lectures, there is other stuff, but if you are in rotation, then you have to give 100% time and attention to that rotation, and this week is going to be pediatric rotation for us, so I will try to get most out of this experience. So before I showed up for that posting, I should know a few basic things about pediatric dentistry, that too restorative part of the pediatric dentistry, and in this video I'm going to show you every time when I'm learning a new concept, I'm going to share it with you. Any information that is good for a DDS third year or fourth year student will be shared in this series of the video about pediatric dentistry. I will start with restorative dentistry, then I'll go in depth about behavior management and child maltreatment. I will also discuss local anesthesia and drugs related to dentistry, local anesthesia and pharmacology, drug doses and different interactions in pediatric dentistry. Day 3 was amazing because it was all emergency, so I will talk in depth about dental trauma and things that you should know about dental trauma in primary dentition. Children are wobbly, they fall, they hurt themselves, and teeth are always prone to more injury. So dental trauma in primary dentition is a very important topic if you're interested in pediatric dentistry. I will also go in depth about early childhood caries, how to prevent it, how to restore it, radiology, local anesthesia, anomalies in pediatric dentistry, and oral pathologies, and many more topics. Throughout the posting, we are always asked questions from our instructor or supervisor, and we have to be ready with answers. So I will share all those answers and those questions with you, and these are the similar questions which show up in your competitive exams as well as in your university exam or viva or clinical scenarios. So if you follow this whole series, I'm pretty sure that you are going to be well prepared for your pediatric dentistry topics in your exam or university or wherever you want to apply it in real life. So there's going to be a lot of learning as well as entertainment in this video series right now. Yep, life is not fun when we have to wake up so early in the morning at 6 a.m. and if my alarm doesn't work, this puppy's alarm always works and she wakes me up at 6 a.m. so that I can take her out, but it's just a perfect good morning watching her play all around me. She's cute. First thing I did was check weather, and it was a nice sunny day, so I decided I would bike to school and take my ferry. Biking is awesome, and I just do not skip a chance to sit on the deck of the ferry. That entire commute is so relaxing for me every morning, and the view of Halifax is, as you can see, breathtaking from the ferry. And the 15 minutes of ferry ride is enough to look at my schedule on my cell phone and see what's gonna happen today and get ready to rock and roll. Look at these bunch of pigeons, so cute. Like, this is a perfect morning for me. From here, next stop is going to be my school, which is Dalhousie School of Dentistry, and then I change into my scrubs, and just across the street is IWK Health Center, where I would see my friend who's going to be my buddy for the day, and we would be on our rotation at IWK Pediatric Dentistry department all day today. So we all scrubbed up and putting your mask on, and we are ready for IWK rotation in the Pediatric Dentistry department. See you there. So the shift starts sharp at 8 a.m. and that's when we report. This is the hallway leading to the dentistry department on the left. And the first thing as we get there is do a huddle. In the huddle, we discuss all the cases or anything new that should be brought towards everybody's attention. And that's when we get started. In our dental program, they teach us how to use materials to treat disease on an outcome basis. Various restorative materials are pit and fissure sealants, conservative adhesive resin restorations, which is called CAR, preventative resin modified glass ionomer cement, which is PRMGIC, and PRR, which is preventive resin restoration, glass ionomer cement, resin modified glass ionomer cements, compomers, resins, amalgam, so many different kind of stainless steel crowns as well as other full coverage crowns, and lastly, modified treatment or atraumatic restorative technique. And the first patient that we got to see during our first day of the posting was a child 7 to 8 years of age with early childhood caries. So if I ask you what are early childhood caries, the answer would come from Canadian Dental Association. Canadian Dental Association recognizes early childhood caries is a complex and multifactorial chronic disease that is heavily influenced by biomedical factors, which is diet, bacteria, and host, and also by social determinants of health. EC is defined as the presence of one or more decayed, non-cavitated or cavitated lesions missing due to caries or filled tooth surfaces in any primary tooth in a preschool age child. That means a child from birth to all the way 71 months of age. The advanced form of this disease, severe early childhood caries or SECC, has raised concerns among health professionals and the public. And overall management strategies should be devised to provide early assessment, prevention, and treatment of ECC so it does not progress to severe early childhood caries. A lot more information is on this link right here, straight coming from CDA, which is Canadian Dental Association. You can go ahead and read it from this webpage, but I'll talk about what should be the goal when treating early childhood caries in children as a dentist. Number 1 should be preventing pain and infection. Number 2 is restoring dentition to function. Number 3 is preventing further disease. Number 4 should be creating a child who will be accepting of dental treatment throughout their life. And lastly, encouraging normal growth and development of the craniofacial masticatory system. In the later part of this series, I will go in depth about how should be the amalgam class 1, class 2 prep, as well as some class 3 and class 5 preparation in primary tooth. But right now, let's check out how my posting schedule looks like. We have a different morning as well as afternoon time. So in the morning, we are in clinics and there are multiple rooms, like there are total 4 rooms and 3 attending pediatric dentists available all the time. And there are 2 residents, there are multiple nurses and dental assistants. So it's an amazing team to work with, and it's a great learning experience for me that I get to see how this entire big team is working together towards improving the health and oral hygiene of little children. So in the morning time, we were just shadowing and following along our attending, and we were just trying to shadow them or assist them a little bit, and just to get a feel of how they work in the IWK Children's Hospital Dentistry Department on day-to-day basis, and how they take care of little children, some with special needs, some with some extensive caries problems, which can only be seen in a hospital setting. Sometimes children are not too cooperative in the family dental practice, so they are referred to this place. So there is a big mix of child patients that we get to observe as well as learn from. So I was impressed that how attending would come to a conclusion that when should they not use any kind of sedation, when should they use some conscious sedation, which may include simply midazolam or a combination of midazolam and nitrous oxide, when would they use any kind of restraints, and when would they actually decide that the case should be done under general anesthetic. So it was a great learning experience when it comes to treatment planning and just understanding the entire life cycle of treatment of a child patient in dentistry department at IWK Hospital. So the first question that I was asked from my attending is, what are various treatment options for a carious anterior tooth? So it's a broad question. So I started listing all possible treatment options, which include silver diamond fluoride, fluoride varnish, interproximal disking, or using composite resin, compomer, GIC, RMGIC, using ART if required, using stainless steel crown, polycarbonate crown if it's an interior, zirconia or resin strip crowns if it's anterior and more aesthetic zone, and extraction, of course, if you cannot restore the tooth. And when I started listing all these, I saw my attending waiting for some answer which I did not give, and that answer was no treatment. Yes, no treatment is also a treatment option. And in our hurry to just come to a diagnosis, we forget that no treatment could sometimes be the best treatment option for certain conditions. So that was a great learning for me, and I hope that if this kind of questions show up in your exam or during your viva, you would be able to answer no treatment as a possible treatment option. Here's a quick picture to show you what are the various treatment options for decayed primary anteriors, and you can see there is a full coverage stainless steel crowns, anterior stainless steel crowns, strip crowns, acrylic phased stainless steel crowns. There is also an option of zirconia crowns, all ceramic crown, as well as the resin facing crown for anterior tooth if aesthetics is a concern of patient or patient's parents. Mostly it's patient's parents. And here's another quick picture just to compare the 5 main type of crowns, which is the resin strip crowns, zirconia ceramic crowns, prefabricated veneered steel crowns, which is the simple SS crowns, and then open phase steel crowns. So they are comparing all these crowns on aesthetics, durability, time for placement, and the selection criteria. So it's a good read. Just pause the video here and make sure that you review it, or just take a snapshot and paste it on your Microsoft OneNote notebook for pediatric dentistry. But out of all these crowns, stainless steel crowns are going to be the most important ones that you're going to often use in your practice, and there are multiple indications for stainless steel crowns in pediatric dentistry. The caries are too extensive, or there is a developmental defect, some hypoplastic teeth, or some condition like dentigenesis imperfecta, amelogenesis imperfecta, or there are so many reasons, like if a child has special needs and cannot maintain the oral hygiene. In all those conditions, stainless steel crowns are indicated in the primary dentition. Other question that was asked from me was, what are the steps when you are preparing for stainless steel crown? So remember that the first step is going to be occlusal reduction. Second step is caries removal. Third step is interproximal reduction. And finally, you will try on different kind of sizes. So throughout the morning hour, we saw tons of cases and learned a lot of content about pediatric dentistry. Now it was lunchtime. We started heading towards the cafeteria at the IWK hospital, and it's a beautiful, beautiful facility where you can find some good food options. All I got was this slice wrap, a chicken wrap, and also a small blueberry muffin and a nice coffee. That's all for my lunch. And while you're eating in the cafeteria, that's the only time I could take my mask off throughout the day. So you know what? It's such a big relief. Damn, yeah, COVID. And if you have made it this far in this video, then please make sure that you subscribe to this video and like it, share with at least one friend. And I have also 2 courses on Skillshare and Udemy. One is on how to ace competitive exams, and my other course is how to prepare for DDS interviews. Please check out those links in the description below and share it with anyone who might need it. Let's resume to the lunch hour. So before I know, my time at lunch hour is over, and now it's time to go for my next posting, which is at OR, operation room. And this is going to be my very first time in the IWK OR, so I'm excited about it. So it's at the 3rd level of the building of IWK Healthcare Center. Before you enter to that wing, you would see this ScrubX machine. So I have to scan my ID, and I would get 1 scrub of my size. So it's pretty easy. Like if I'm large size, then I would feed in the number and I would deposit my scrub back on this side, and I would have to scan my card once again. So it's a pretty cool system. The efficient way of washing and laundering the scrubs. Looks like I cleaned up nice. Let's go. Now it's time to put my head cap on and get ready to get into the OR. I'm excited, but I'm also trying to recall all the details about any kind of pharmacological or anesthetic related dosage or interactions that my attending may ask me. And a common question that you might get asked is, during conscious sedation in child patient, what is the dosage for midaz or midazolam? And the answer is 0.5 milligram per kilogram. Another common drug used in pediatric sedation is hydroxyzin or atarax, but I did not see that used during my rotation. Pediatric dose of hydroxyzin is 0.5 to 2 milligram per kilogram with a maximum dose of 30 milligrams. Nitrous oxide is an excellent option for conscious sedation in children as well as adult patient, with the exception of being one condition when you should not give nitrous oxide, and the answer is COPD, chronic obstructive pulmonary disease. Just another MCQ question that might show up. Another question that I was asked from my attending is, what could be some of the challenges when restoring a primary tooth in a pediatric patient? Some of the answers that I came to on top of my head were subgingival caries, poor isolation, difficulties with rubber dam isolation. Sometimes you can't even put rubber dam because the tooth is so small. Hemorrhage control. Then we have to also think about if there are early childhood caries, that means they might not have a proper oral hygiene maintenance at home. So we have to consider material that would be more suitable for a patient who might not have enough great support for oral hygiene at home. We have to discuss marginal plaque, marginal gingivitis. Primary teeth might have large pulp or pulp horn, so we have to also look for those. And lastly, we have to depend on patient cooperation. How much can we do in one day? Other kind of supports, conscious sedation or complete sedation options. So many factors as well as challenges that we face when restoring carious primary tooth. And my friend Hatim and I got together for a quick coffee break, and I discussed so many questions with my friend Hatim. He was asked about silver diamine fluoride. So silver diamine fluoride arrests active caries, especially in kids with rampant early childhood caries with little access to care. Those who are waiting for GA or those who would need a full mouth rehab. If you have a lot of carious lesions and you might not able to restore them, but you think that there is not much loss of tooth structure, then you can actually apply silver diamine fluoride. He also shared some questions that he was asked about no treatment option. Consider child's acceptance age of treatment. Child may cooperate. We start sensitizing the child with the dental clinic and all the operatory around us. Just a sound of drill, do a little bit, just make them sit in the chair, do some knee-to-knee exam, get used to taking radiographs and so many things like that. So no treatment option is amazing when you just do not do the treatment. You just give child some introduction or some orientation to the dental clinic, and next time, maybe after 6 months, they might agree to perform a treatment. You might consider use of silver diamine fluoride or some varnish. That can be done actually during knee-to-knee exam or in a very, very quick way. If we see arrested caries, first of all, it's important to make a diagnosis of arrested caries, and then we do nothing. Consider space loss, food impaction if extracted. If the teeth is about to exfoliate, consider the mobility of the tooth. Will tooth fall out in 3 months? If not, then maybe consider interim restoration again. Consider the size of the lesion, food impaction issue. However, we always try to allow the tooth to exfoliate by itself. And he was also asked that what is the main thing that you consider when extracting a primary tooth, and the answer is space loss, because that's the biggest concern. Yes, primary tooth anyway is gonna fall out, but what is something that you have to consider before extracting that primary tooth is, would there be a considerable space loss? There are many conditions when if you take the primary tooth out, there would be no space loss. And lastly on this topic, some short notes about amalgam and other restorations. So for amalgam, remember this strict thing that the width of the isthmus in class 2 or the width of the cavity in class 1 amalgam prep should not exceed 1/3 of the buccolingual width or 1/2 of the intercuspal width. It is part of the DPES videos from University of Toronto series. So this is a common question that keep popping up in all kind of exams. Also, the most failure of amalgam restoration is due to isthmus fracture. The axial depth should not be more than 1 mm in class 2. In class 3, depth of gingival seat must just clear the contact with adjacent tooth, and amalgam is actually the material of choice for class 1 and class 2 restorations in primary tooth. Only exception is when the tooth is grossly carious. SS crown would be the restoration of choice. And on the left, you see a quick comparison between survival rate and replacement or recurrent caries in amalgam versus composite. definitely amalgam is the winner. Again, when it comes to class 3 restorations, there is some tricks involved, but I'm not going to go in depth. Just remember the important points that the proximal slot only prep with buccal or lingual extensions can be done in class 3, caries of incisors and canines. Remember that the distal surface of canine is the frequent site of caries attack. That's why we do a modified class 3 prep in which there is a dovetail placed on the lingual surface of maxillary canines. And if it's a mandibular canine, then we place the dovetail on the buccal surface. Finally, my posting is done, and I would return my scrub into this ScrubX machine. As I showed you earlier, scan the card, pull the drawer, put your scrubs back in, and it's all good. And that's all for this video on Restorative Pediatric Dentistry. It's my time over as well, 4 o'clock, and it's time to head home. It was a lot of learning in this one day, and I'm really excited to see what rest of the week brings in terms of knowledge as well as experience. And before I got into dental school, I always used to walk by this IWK hospital. I have taken my daughter here a couple times because it's the only children's hospital in the 4 provinces, and our school is just across it. But this is the first time I'm working inside this healthcare center. So in the next part, I'm going to talk about behavior management and knee-to-knee exam, which is a very amazing thing that I learned at IWK and in pediatric dentistry in my school. So I'm going to share how the knee-to-knee exam works and how it can make your life while examining a child patient so much easier and better. And then I come home to this little puppy. She usually waits for me right here. And when I get home, she gets super excited. I know. Say hello to everyone. I don't know how exactly she know what time I'm gonna come, and she would always ask my wife to open the door and get out and wait for me at the doorstep. She's so cute. And that's all for this day. Maybe I'll see you in my next video and this puppy calms down a little bit. Bye.